Welcome to Nurse Practitioners Changing Practice. I'm Carol.
Hi, I'm Nina.
We are so happy you are with us tonight. We have another episode of Ranking Differentials, so you are going to help us solve another mystery. We want to take a moment to thank you all for listening, whether it be on the podcast or the YouTube station. We want to thank you for your comments. We read all of them. We get really interesting stories. We got an interesting story today about another person, an NP, who suffered from vocal cord dysfunction herself. And so please keep those stories coming because they give us more cases to be able to share with our viewers, right?
That's right. We really appreciate those stories and keep them coming, or suggest to us what kind of diagnosis you want us to do a differential about.
So here we go. We're going to solve another mystery. I'm going to share my screen. There we go. All right. This is episode 4. I can't believe we're already there.
Can't believe it.
And again, the only difference between a novice NP and an expert NP is the amount of stories in your library. So we are going to continue bringing you stories so you can build your memories and be able to pull from them when you see a patient that has similar symptoms. Let's go to the first page. All right. And it goes too fast, so I'm coming back. Okay. Pam is 42. She's come into your hospital with a potassium of 2.7. She passed out.
Okay.
She tells you that she was started on a blood pressure medication by her primary doctor a month ago, and he added hydrochlorothiazide about a week ago because there had been no change in her blood pressure. So most of the time, obviously she was admitted, we're going to supplement her potassium. We're not going to give her hydrochlorothiazide anymore. But upon further investigation, I looked back at her labs, and 2 months ago, I noticed, because she said to me, my potassium, that's I think the clue that I had. She goes, my potassium was low before I started my medicine. That's why I looked back even further. And she was right. It wasn't a very low. It was 3.2. And everything else is pretty good there, right? But it was low. So now her labs are about the same, except her potassium is 2.7. And you can say, well, yes, the hydrochlorothiazide made it worse, right? Maybe. But what's the problem? I mean, did the hydrochlorothiazide really cause the initial potassium to be down?
No. Not if it was starting to go, not if it was starting to lower before the hydrochlorothiazide, if you see a trend there. Perhaps it's not that medicine.
Potassium is something that you have to say to yourself, is it usually the only thing that affects it is diuretics or hydrochlorothiazide? Sodium, if it's low, hydrochlorothiazide is another big problem with that. But so are all of your antidepressants, your SSRIs, SSNRIs, those get missed a lot with sodium, but her sodium is normal. Just her potassium is low, and she's got high blood pressure. So we have a couple of differentials. Whenever you see high blood pressure and low potassium, you have to start thinking adrenals might be having something to do with it. And you think back to your patho with hypertension and the renin aldosterone system, angiotensin and all of that. Aldosterone makes you hold on to water. So if you have too much water, you're going to have high blood pressure, right? And it affects your potassium. It'll drive your potassium down. So what are our clues here? She did have hypokalemia prior to starting any blood pressure medicine. She did have an elevated blood pressure. She wasn't on thiazide diuretic at that time, right? And then so if it was just the hydrochlorothiazide that was doing it, yes, she could have hypokalemia, and it probably did make it worse. She's on a thiazide diuretic. But what do you think is going on with her?
Yeah, something's going on. Maybe with the aldosterone, you have to consider aldosteronism, a primary, in other words, a not essential hypertension, but secondary hypertension. Young person, maybe adrenal tumor. We're not sure yet.
No, but there's something going on with that system. It's not just essential hypertension. And that's what you really need to take away from this. Whenever you see low potassium in the presence of high blood pressure, it might not just be essential hypertension. In this case, it did turn out to be primary aldosteronism. So let's look at what UpToDate says, right? UpToDate says, consider testing for primary aldosteronism in patients with any of the following. Hypertension and hypokalemia is the first on the list. The second one, which I've run into quite a bit, is resistant hypertension. This will be your patients that say, I'm on several drugs and my blood pressure is never controlled and I take my medicine all the time. It just doesn't help. And they have severe hypertension. Sometimes they come in with hypertensive urgency.
Yeah.
And so that is that person that you're looking, they're on all these meds, their blood pressure is very hard to control. Maybe we've missed primary aldosteronism as the problem. And you said something interesting, Nina. It could be a tumor.
Could be.
Yeah, it sure could be. And you want to wonder about your secondary sources of hypertension in any of your people who are super young or who come in with really severely high hypertension. So what do? How do you find it? Well, first of all, you want to refer probably to renal.
Yeah.
That is the people that are going to get the secondary hypertension more so than a lot of people I see will send to cardiology, but cardiology is really more to do with the heart and arterial sclerosis and MIs and arrhythmias, where your renal doctors really know secondary hypertension as well. They really can do that well. Excuse me. I swallowed the wrong way.
You okay?
Yeah. So how do we go about diagnosing it? Well, the eval would be getting some plasma renin activity tests or plasma renin concentrations, plasma aldosterone concentration. These are the typical tests that you would run, and UpToDate will go all through this for you and tell you exactly what you need to do. Or like I said, you can keep them on an antihypertensive. Just stay away from diuretics that are going to make the potassium worse. You don't want to do that. We got to keep the potassium up a little bit and then send them off to renal. But be on the outlook for your patients like this, because you'll be surprised when you start looking for it, how many times you'll find it.
Very interesting. Something that, I for sure could, I remember sending a patient to renal about 6 months ago, and they were looking at secondary causes for hypertension, such as this issue. So
yeah, and I mean, UpToDate even tells us a lot of times we're used to getting a renin aldosterone ratio.
Yes.
UpToDate really said that they don't recommend that.
No.
The individual tests are better. So
yeah,
that's
interesting.
Run them. You can get them running and send them to renal. That way they'll have the test results when they get to see the doctor. I like to do that because that way they don't go see the specialist, then have to get the test ordered, then go see him again. The specialist kind of has the tools that they need. And a lot of times too, I'll give them a call and I'll say, I'm sending you a patient and this is what I suspect. So they know kind of what's going on, and that really builds that collaboration between you and your specialists.
Yeah, which is really important.
Well, we want to thank you guys for listening again. We will continue to bring you new and interesting cases as they come, and continue to give us more ideas of what you would, what different cases that you've seen that are really interesting, because we'll make up a scenario for them and present them.
Give us a hint and we'll present it.
Yeah, I mean, we're a community of NPs and we can learn from each other. So we will see you again next week. Thank you so much for listening. Be
Bye-bye.
sure and like, share, follow our podcast and our YouTube presentations so we can bring you more.